and very important that we don't forget the hinterland, and particularly the rural area, and the role of the very fine public health nurses and nurses that actually provided a lot of the nursing and healthcare in these areas. And those of you who've seen some of the early newsreels will see these very intrepid nurses who went around the countryside from fighting the flu epidemic in 1918 up in the very hinterland, and also then subsequently tuberculosis when there were little huts put everywhere. In any case, it's those of us who post-war know that the nurses have also been very important in thinking about when there's been economic downturns, and farmers have found it been struggling really hard to keep on their farms, and so there were big mental health issues, so that these nurses, and we're very lucky to have Margaret Pittaway with us today, have multi-skills and very intrepid. So Margaret's going to talk to us about the realities for rural health in New Zealand, and it started in 1927, the Women's Division of Emergency Housekeeping Scheme, now the Rural Women's New Zealand Association. And she joined New Zealand Rural Women New Zealand in 1996 and was elected to the National Council in 2011. She herself is a nurse, but she's talking about this more general rural women's organisation. She was the founding member of the Central Otago Women in Agribusiness Group, past president of the Cromwell branch and Central Otago Provincial. She's a retired nurse, and her key specialties are in rural health and social issues. She is the Rural Women's New Zealand National Board member, and she is their health spokesperson. So we're delighted to have you here today, Margaret, and thank you very much for coming to talk to us. Did you come up all the way from Dunedin?
I flew from Queenstown yesterday.
Oh, and came up from Queenstown yesterday. So thank you very much.
Thank you. Rural Women New Zealand has been working hard to strengthen rural communities for over 90 years. We have been a leading voice for rural families and communities since our beginning in 1925 in the areas of health, education, social and environment. The issues in the 1920s that affected the women, their families and their communities still exist today. Isolation, lack of services and agency support. Their concerns then were around health and education for themselves and their families, and being connected to the outside world and able to access the services that they needed. In the time that I have with you today, I want to talk about the difficulties rural New Zealanders face in their day-to-day lives in accessing health services, and to give you some of the reasons Rural Women New Zealand believe to be the main cause of our problems. The organisation began 92 years ago when a group of very determined farmers' wives took the opportunity to meet in Wellington while their husbands attended the Farmers' Union conference. These women recognised the need for representation and support for rural women in the areas affecting the welfare of women and children, and they were concerned at the stories they were hearing of loneliness, illness and lack of assistance. One of the prime needs was to organise reliable help, to step in when the women were ill, needed support when there was a new baby, or when they needed to leave home for a time for whatever reason. And this was the very beginning of the Women's Division Emergency Housekeeping Scheme. And in April 1927, advertisements appeared for housekeeper willing to do anything, and for bush nurse with surgical skills and maternity certificate. And yeah, thanks. These nurses were the beginning of the district nursing services and community midwives. Nurses' wages were subsidised with donations from all over the country, and the numbers employed were initially quite small, and then the government of the day began to set up cottage hospitals and a district nursing service, and the need for our bush nurses disappeared. During this time, homes were purchased throughout the country to enable members to have respite care when the need arose, or to take a family holiday for very little cost. When there was no longer the same need for this service, the homes were sold and the funds were used to set up a company, Access Home Help, which operated throughout the country and continued to provide care to rural areas in spite of the time and travel costs involved. The only company to do so. Access was sold in 2014 and continues to operate in the same manner under new owners. In 2000, the results of a rural health study undertaken by Rural Women New Zealand were released, with the hope and the idea that it would be used as a basis for planning for health services by DHBs and other health providers. Today, I acknowledge the document as it remains relevant and was helpful when it came to planning this presentation. In 2016, Rural Women New Zealand undertook to study rural communities in New Zealand so that we gained a better understanding of what and where the problem areas are. And other than this document, there is very little to find in the way of rural research, but we have found that our document is a valuable tool for us, particularly when we are preparing for submissions. Rather than being a negative work, gives examples of positive actions which have meant that the fortunes of communities have been turned around, both in New Zealand and in overseas communities. The biggest disadvantage for rural New Zealand is that there is no accurate definition of rural. Government uses the New Zealand Statistics definition of rural, which divides into 4 categories: rural with high urban influence, rural with moderate urban influence, rural with low urban influence, and highly rural remote. What these categories mean is that 40% of people who access rural health services are classified as urban. And a further 20% of people currently classified as rural access their health from urban. In response to a very recent request from our National Office for information on statistics for cervical cancer and for the uptake of immunisation with comparison between urban and rural, the reply from the Ministry of Health was, generally speaking, the Ministry doesn't do much analysis looking at urban-rural discrepancies because there are some inherent biases in the way automatic geocoding copes with non-specific addresses. These addresses, which are most likely to be rural, tend to get recoded at the nearest post office, and this means that a sizable portion of rural people are recorded as urban, making any attempt to draw meaningful conclusions impossible. This statement on its own underlines the absolute need for rural research. We currently have a rural population of some 620,000, making it effectively our second largest city, though spread from one end of the country to the other. And yet we struggle to get the equivalent services that the rest of the New Zealand population expects. We just do not have sufficient information to provide evidence-based interventions to most effectively create better health outcomes. What we and other key rural organisations would like to see is a system of rural proofing of government policies reintroduced. The system is used in the United Kingdom and ensures that the impact of changes in government to rural communities with low population density is taken into account as plans for change are developed. So what are the concerns we have, and what are the realities in accessing healthcare for rural New Zealanders? Let's start with maternity services and some information shared with me by a young woman living in Te Anau, a major but isolated tourist town with a growing younger population. The nearest available midwife lives in Tuatapere, 101 kilometres distance, and her backup midwife has her home in Riverton, a distance of 147 k's. Although there are 2 other midwives who do work in Te Anau, they do not live in the area and they both have a full caseload. Further, there is no opportunity for any of the young pregnant women in Te Anau or the surrounding areas to attend antenatal classes. Their nearest birthing unit is in Lumsden, 77 kilometres distant. As with a number of units throughout the country, it is in danger of being closed, and so young women are making the decision to go to Invercargill to have their babies there, as they feel safer there, and they want the assurance that the unit will still be operating when they do go into labour. This is a trend that's happening throughout the country, which is regrettable but understandable. But if these units continue to close, it leaves no options to have extra time after the birth in a unit where there are staff to assist a new mum and baby in those all-important first few days. Most birthing units encourage their new mums to return home early with no thought of a farming mum who will be quickly caught up in the day-to-day business of farming life, and with no support services close at hand. There is not much rest for a rural woman. And there is provision for a midwife to arrange for a longer stay in the birthing unit or other facility on the grounds of geographical isolation. During the first trimester, the midwife must discuss with her client the plans for managing her pregnancy and the 6 weeks following birth. An agreement of expectations about the number of postnatal visits must be reached. New mums are entitled to 7 visits, but they may not be requested or required, or they agree to 1 home visit with the mother and then undertake to travel to a clinic for the other postnatal checks. No problem with that. But if a C-section has been performed, the new mother is not permitted to drive for 6 weeks. If baby's arrival coincided with a busy time on the farm, say for example lambing or harvesting, it's nigh impossible for a farmer to take his partner to an appointment, and other friends or neighbours are likely to be busy at the same time. And the value of regular checks in those first 6 weeks cannot be understated, as they provide the opportunities to ensure there are no unrecognised signs of child or maternal health problems, to say nothing of the reassurance that new mums seek and need. We haven't touched on the birth yet, but if lengthy travel to the birthing unit is required, then careful planning is needed to ensure that the pregnant mum is resident in the area before the onset of labour. Get it wrong, and the stress and anxiety mount, to say nothing of enduring contractions on unsealed, bumpy roads and adverse weather conditions. Midwives have reported on the difficulties of using ambulance services to transport labouring women experiencing difficulties to a primary birthing unit. The irony is that if you happen to break your leg on a ski field, doing something way beyond your capabilities, there is no question about the need for a helicopter. So what price the life and well-being of a mother and new baby? We don't know whether our children are disadvantaged because they have poorer access to maternity and youth health services than urban children. There is no data available. The rural population is facing the reality of an ageing and burnt-out GP workforce and a seemingly dwindling number of younger doctors who are willing to take up the challenges and the rewards of working in remote rural areas, despite best efforts to promote and attract. The uncertainties around continued local medical service takes its own toll on our rural communities, with reluctance for families to work in areas where the facilities are unreliable. Add the lack of ultra-fast broadband and poor cell phone coverage in many areas, and it becomes apparent why there is a reluctance to work in these areas. The use of locums means that a relationship of knowledge and trust is difficult to build. And for our older patients in particular, this is a very real problem. Currently, 25% of rural general practices are seeking a full-time GP, and over a third of pharmacies are having difficulty with recruitment. Consider the need for an outpatient appointment for a family member. Urban dwellers will allow maybe 2 hours out of their day to get to the hospital, find parking, attend their 15-minute appointment and be on their way home or back to work soon afterwards. For someone living in the country, the reality is entirely different, where travel is a necessity. Hospitals are not always good at recognising that a patient has to make a real effort to attend an early morning appointment, and that it may mean an overnight stay. Travel costs are prohibitive to many, as are accommodation costs. And it also takes people away from a busy farm life, so there's work loss there as well. For many, A specialist appointment can mean an 8 to 9 hour round trip and loss of a day's work or wages. Yes, there are increasing opportunities for telehealth consultations, but generally speaking, the majority of patients will need to travel for their appointments. The distance that cancer patients have to travel for treatment is significantly further for those living in rural areas, and often women with breast cancer will choose a more aggressive treatment in order to get back home to their families quickly. And any patient undergoing prolonged treatment will struggle with the travelling and the distance, particularly if they have no one else to drive them. Difficulty is often experienced in accessing drug and alcohol services and counselling services. Accidents in rural areas pose more problems. We are reliant on a largely volunteer ambulance service, which means that the crew need to be called into the station before the ambulance can even leave. Time lost. In most rural areas, stabilising the patients for transport to a base hospital is the main aim. In severe cases, helicopters can be called into transport, but that takes time too, and adverse winter conditions may mean that the choppers can't fly. Time lost. Winter road conditions for ambulance transfer may well mean a slower than normal trip. More time lost. And the reality for many of us is that the base hospital is 3 hours away by road in good driving conditions. Consider also that many of our high-density tourist traffic areas have very poor cell phone coverage, which can mean more time delays to get urgent help on the scene. Let me touch briefly on the volunteer system that is the reality for the rural population. And don't get me wrong, the people who volunteer in any service to their community are fabulous. But it comes at a cost to them and to their family. On call means just that, the need to abandon all plans and activities to answer an urgent call out, sometimes in the middle of the night. Depending on the reason for a call out, realistically it could involve hours with the initial need for assessment, stabilisation, transfer, handover, return journey home, and then the absolute need to clean up and restock the ambulance so that it's ready for its next call out. Many of our volunteers also have day jobs and responsibilities which they have to consider, as well as the fact that training that they need to undergo to continue as volunteers is taken in their own time with very little recompense. Volunteer ambulance staff are being put under increasing pressure as they are filling the gaps left behind by 24-hour services that have been centralised. Not only do our volunteers need our recognition and continual support, but also their families who miss out on family time. We are all aware of the state of our mental health services in the country, and ponder for a moment on what this means for rural communities where we have a high suicide rate in our farming communities, and particularly in the male 20 to 25-year-old age group. Rural support trustees report that when they have a suicidal client, they have little problem in accessing GP assistance. But when it comes to getting further help in the form of an urgent appointment from brief intervention services, the wait can be from 10 days to 3 weeks. Not good enough. Can you just imagine the anxiety and stress that the family will experience during this time? Consider those who are patients in hospital, who are sometimes discharged at short notice to make way for another patient, at times in the middle of the night. If they live in a rural area and have been brought in by ambulance or a friend or family member, how do they get home? Or where do they go if they have no family living in the area? Very discretion, again, particularly for the elderly or those who are still unwell. There is unlikely to be any available public transport. Many are not permitted to drive after surgery, and so are reliant on someone yet again to be able to take time out to collect them, and home could be a good distance away. Often when patients are discharged from hospital, they require ongoing care, maybe wound care, maybe drug administration or assistance with the usually simple tasks of showering and dressing. In an urban situation, it's simple, as the district nursing service is able to administer those treatments. Not so for rural patients. And we have had a number of our members approach us for help and advice when treatment at home has been refused. And I do not use the word refuse lightly, as I have been told by nurses that the service and the extra cost of travel to rural areas is just not within their budget allowance that the district nursing service gets, and even worse, that if people choose to live in the remote areas, then that's their own problem, their own fault. So how do we get around the problem of getting continuing treatments once a patient is discharged? Some elderly people may qualify for respite care, and in a few cases that's worked really well. But for the majority, it means frequent travel to a medical centre for the cares that are needed, involving not only time and travel costs, but fees incurred at the medical centre. I have briefly touched on connectivity, but I want to return to the topic as it is in fact a major issue in rural areas for a good number of reasons. Firstly, for safety and access to rural services. When an accident occurs in a rural area, there is often no cell phone coverage because of black spots, and so it requires someone to find access to a landline or find somewhere where there is cell phone coverage to phone for help. Not always easy if those seeking help are visitors to our country or are unsure of the area that the accident has occurred in. And if those involved are injured themselves, they may not be able to send for help. So we think about our farmer at the back of the farm who's had an accident. Unfortunately, much of the vital golden hour can be taken up finding help. As an example, a farmer who had an accident with a digger and badly injured his hand was just fortunate that he had satellite internet, and so he was able to call for help. Phone services had been out for a week and there was no coverage for cell phones. Further example, in a small settlement where the phones were out of order, a motorcyclist on an event was injured. In this instance, a helper had to drive 20 minutes to the nearest town, then drive a further 20 minutes to find a phone that worked, while the injured person lay in pain until help arrived. The nearest ambulance was over an hour away. Even with a first response team on site, it was an unpleasant wait. If cell phone coverage had been available, that time could have been significantly less. In an emergency where there is only a landline already in use for contacting emergency service, there is then no opportunity to call for extra assistance from close neighbours or friends. It can be a traumatic and distressing time for everyone involved. I spoke earlier about the pending closure of maternity hospitals, and I wish to make further comment, and this time includes some of the smaller general hospitals. The downgrading and closure of rural hospitals has left a gap in rural health and emergency services in communities throughout the country, for they provided an essential focus and service in the communities they served. The effects are variable, but the increased separation between patients and vital services is creating barriers to access health services. Closer to my home, Kurau is a small service town in North Otago. Its medical centre is open 4 days a week, and an after-hours service is provided by volunteers. The town pharmacy closed some time ago, and until recently, prescriptions were brought down by a car daily from Twizel and delivered to a local shop owner who was licensed to give the prescriptions to the locals when they called in. Regrettably, the owner has decided not to renew her licence, and so now a car drives from Twizel each day, parks on the street for 1 hour so that prescriptions can be collected, and then returns to Twizel with any unclaimed prescriptions. A round trip of nearly 160 kilometres, and a service that is inconvenient in general for the local population. And has anybody given consideration to the safety of the person in the car if it becomes known more widely of its contents? A local resident, Bill, aged 82, has a number of health issues including prostate problems and blindness in one eye. He has been waiting at great length for eye surgery with no operation date on the horizon yet. He is unable to do much at all in his daily living. Bill's comment on the situation, apart from his disillusionment with the state of the health system, is that he has had enough and he's ready to die. This brings me to my final point. Evidence from a number of countries states that those who live rurally have poorer health than their urban counterparts. There is little information about the prevalence of illness or disease among our rural populations, but it is reasonable to assume that its rates of illness or disease are similar to those of the rest of New Zealand. However, once diagnosed, rural people unquestionably face greater challenges and costs to access health services and specialist treatments. It is also reasonable to assume that there is far greater impact of disease or illness on rural people and their families. It is also a reasonable assumption that this results in poorer health outcomes. I hope today that Rural Women New Zealand has successfully brought our concerns to you, and that the word will be spread that our rural population deserves better treatment and consideration. And I'd like to acknowledge the help and support from my peers, from our National Office staff, and the health organisations who we work with in partnership. Thank you.
Thank you very much for that very interesting account, very heartfelt. Are there questions that people would like to raise or comments they'd like to make? And could you please say who you are?
Thank you, Margaret. Marie Russell. I just want you to clarify, please. You mentioned the figure of 600,000 plus as a population of rural people, but I was a bit confused about the definition of that. And you said the definition is confusing, the statistical definition. So what does your number include?
Right, we're looking at the combined population of those who live rurally. Which makes up to a figure of 620,000. Yeah, 620,000. So in effect, that's 620,000 who are not getting the same services through distance, time, cost, whatever, as the urban population group.
But does that include what you call urban rural?
I'm actually not sure on what that was based on, quoting from another organisation who has done that research. So without input from them, but I think probably that they have looked at the small urban townships throughout the country where there is isolation and genuine isolation from main base services. Thank you.
Hi, I'm Jude Bull. I just wanted to come back to the comment you made about, the skier who breaks their leg can be helicoptered to hospital, whereas someone giving birth can't. Can you explain how that works, how the services are funded?
Right, because that person who breaks a leg on a ski field is covered by ACC and the requirements and it's an entirely different look at the situation, whereas a labouring mother. Now, we had an example in Central Otago where I think it was a lady from Queenstown was going to be asked to change ambulances on the way to Dunedin about 3 times. They were going to take an ambulance so far and then get the poor labouring woman out and transfer to another vehicle and then further down the line, so that it was going to be a very uncomfortable trip for her. And there have been delays reported in getting ambulances out to women, and so that's where that idea comes from. But yeah, it's the ACC component of it. But I think it's a fair comparison to make, because to me, the health of a mother and baby is important, and we've seen statistics this week that are saying that we're the poorest, amongst the poorest in the country and in the OECD countries because of our family violence and poverty, with the appalling death rates amongst neonates. So we want to do something to turn those figures around. But that's another problem. But
thank you very much. Mary McIntyre, Public Health. I come from one of those rural communities like the one you described, but this one was in the North Island. And I think what we've seen in our town is probably very typical of a trend over maybe the last 40 years, in that once upon a time we actually had a lot of services. We had a pharmacy, we had a maternity home, we had a GP, and he had an offsider. And all those things have disappeared, but at the same time, the population has changed too, and that a lot less people work on farms because of the mechanisation, and the fact that a lot of farms, particularly those allocated post-World War II, were actually quite small, and so they've amalgamated. I also come from an area that had a number of railway settlements, and the railway settlements always had 4 or 5 houses to go with managing their section of line, and all those things have gone now. But is that a sort of trend that has been apparent over other parts of the country?
Not only in New Zealand, but I've been fortunate enough for the last 2 or 3 years to be able to attend Rural GP Network conferences, and with speakers from Canada, Australia, and somewhere else, Scotland, I think. The trends are very similar. With farmers, with mechanisation, farms have got larger, and the need for the same number of people working on them, and it all compounds. And I know it's not an easy problem to get around, but my task today was to tell you what you know, the problems that rural people are experiencing, and they are very real problems. You know, some small communities are making amazing turnarounds by looking at themselves and finding what other areas they can invest in and create work in their communities. And I'm very lucky that I come from Central Otago and Cromwell, which is probably one of the towns in the country that at the moment is really booming. But having said that, it's putting more pressure on our local hospital at Dunstan, which is a superb establishment. But in the paper this week was notification that there is now a 9-month waiting list to have an ultrasound scan. Now, fortunately, pregnant mothers are considered as being urgent, and so they're still getting their scans to monitor the progress of their pregnancy and ensure that it's all well. But if you're somebody who maybe has a rotator cuff syndrome and needs that scanning so that you can get an appointment with an orthopaedic surgeon, the options are either to travel over to Queenstown, and if you're lucky you might get an ultrasound scan over there, and that's from Cromwell about an hour's distance away, or you go to Dunedin, where no doubt the services are still under stretch there as well. So, you know, even for growing, there's still a price to pay for the amount of growth and the amount that the hospital services can expand with it to cover that area.
Other thing I have seen in the rural community, and this is certainly our experience, is that quite a lot of areas have been subdivided for lifestyle, and
yes,
a lot of lifestylers have moved in, but the lifestylers don't want anything to do with the local community.
No, and
they come for a weekend's fishing or whatever. The children don't go to the school, and they don't really contribute very much.
Yeah, and that's actually a comment that I picked up on a paper that I've read in the last couple of weeks in preparing for this, is that it's affecting our maternity services because they have the desire to go somewhere to a primary birthing unit, and that's setting a trend amongst other younger women too. And from the College of Midwives, we had an answer to an email I sent, and they feel that there's been a fear factor instilled in some of the younger women about what is actually a very normal process is becoming a bigger thing. And yes, we know we want, you know, the best outcome for it, but it is taking its toll on our small hospitals, and there is no easy answer. One down here, Virginia.
Michael Orchard, just here. Do you have any overlap with the remote Maori communities? Maori Women's Welfare Leagues have quite strong organisations, and I travel quite extensively, but also as a background, I have a doctor friend, a junior doctor, who travels regularly from Rotorua to Murupara to give do 2 or 3 days surgery. So just wondering about the additional support that some Maori women's welfare groups provide. Thank you.
I'd love to be able to comment more favourably on that. We have tried to work with the Maori population on a number of occasions, and at conferences I've spoken with people, with Maori women who have a good insight into the problems that they have sometimes with accessing service and getting services and the need for them. But it hasn't worked that they've come back to us for more support. It's certainly there because we cover all ethnic areas and support them, but it just hasn't been forthcoming. And personally, I'd love to be working more with the Maori population. We've had some great support recently. One of our things that we've done this year is we've set up a charitable fund. This is a bit off the track, but it may give you an idea. We've been giving out $1,000 donations to some of the people who have been really adversely affected up around the Bay of Plenties where they've had floodwaters through their house, and also in the South Island as a result of the earthquake there that happened in November. So we've been able to help an amazing number of people, but I've done some work with an amazing young Maori woman from Edgecombe who initially applied for a grant herself, and I suspect she didn't tell me the full force of the impact that came through her own home. But the next request I got in was from somebody else, and this lovely young woman, Irana, was the person who was being spokesperson for her, and she is very active in the Maori youth group attached to the Marae in that area. So in some areas we have been able to help. We would like to do more, and I hope that answers the question. It's not as I would like to be able to answer it, but any opening we will look at. What is Rachel going to say?
Many years ago, I was a board member on the Southland Area Health Board, a government appointment, and I've been out of that area for quite a while now, and of course a lot of changes have happened with the Southland Hospital and the Dunedin Hospital, and I wondered, with it coming from that area, if you can make any comment on the change in services to Southland residents, given that Invercargill is probably around a population of 50,000 people, so technically isn't even rural, because from what I've heard through family members and personal connections, and to the experience of a close friend that I nursed through terminal cancer, that the service has somewhat reduced. So if you've got any information about that, I'd be very interested to hear it.
Yeah, I can only comment on something that came out. I think Rural New Zealand were doing a health survey. It came through, I'm not quite sure in what context it was done, but there was a comment that came from our Southland members to say that they were totally disillusioned since the amalgamation with Dunedin and Invercargill, and absolutely appalled to be found that they were now being described by Dunedin as being a rural hospital. And so effectively, just from that attitude, they've been downgraded there. And yes, I would think that's probably fair comment, that they are genuinely missing out on services. And for the Invercargill people, you're talking about an 8 or now 9-hour road trip to access services in Dunedin. So yeah, I think they have been done an injustice, and I may be shot down in flames for that statement.
Anybody want to comment who's lived in other countries that have got declining rural populations? For the solution? Okay. Well, any other questions? Got a question?
Presumably the Women's Division of Federated Farmers, is that correct?
Yeah.
A rural woman came about.
We began as the Women's division of the Farmers Union. And then the Farmers Union became Federated Farmers, and we then became Women's Division of Federated Farmers. And then about, I can't remember the date, we did some rebranding and called ourselves Rural Women New Zealand, because we just felt we wanted to be a standalone organisation. We still work with Federated Farmers, but just known by a different name with a little bit more standing, and hopefully shaking off the image of tea and scones. So we do much more.
You've got a new woman president now, West Coast.
Yes, exactly, Katie. Yep.
I was going to ask you a final question. University of Otago, in its medical training, has taken quite seriously some of the issues that you've talked about, and there's now a possibility for young medical students can choose to do part of their training actually closely with rural GPs, and I wondered if you had any experience of that and could give some feedback on that.
Yes, I worked for a number of years at the Cromwell Medical Centre, and it was quite common for us to have young medical students coming to the Cromwell Medical Centre to work alongside the GP there and gain experience in real medicine, can I say it? Because I just have so much admiration and faith in our rural GPs who work often in isolation, and sometimes quite difficult for them to access a specialist or somebody from a base hospital who can help them with a problem. So the training that these young students get, I think, is really good. And not only that, while they're living and working in the area, but the ones I've dealt with have been based at Dunstan Hospital and get sent out to periphery medical centres. They also do some research into the actual community and come and talk to service groups around and find out what the problems are for those people in the area, and then give a presentation back to the community. And it's a lot of fun, and they gain a lot from it, and it's the initiative is a real positive for these young people who have entered into the rural GP training side of their education as a medical student. So you have hats off to them, but all of these things help, and you know, there are some great things happening. It's not all negative for rural health, I have to say that. There were some real positives, but generally speaking, we are at a disadvantage in accessing services.
I've had an email from someone asking if you're going to be doing this presentation in other parts of the country. Sorry, I merely pass on the information.
I shall probably have to refer back to our financial officer. That question needs to go back to the board, and yeah, it's not my decision.
Well, I'd like you to thank you very much from the audience here for a very thoughtful presentation and drawing things to the attention of the city audience. It's being filmed and people can access it from a distance, and it will be on the website if you're agreeable to that.
I have agreed to it.
But nevertheless, there's something compelling about hearing you talk about your experiences and the experience of your colleagues. So I'd like you to join with me in thanking Margaret.